Dr. Fairooj. I want to be it an interactive session. This was a 43-year female who came with diplopia, lid swelling for 2 weeks with mild pain, dimness of the vision in the right eye, finger counting, visual acuity in the right eye with RAPD, extraocular muscle restricted, disc edema. So clinically, what do you think? What it could be? So this is the MRI picture. The muscles are enlarged. All the recti muscles are enlarged. Look at the lab investigations. Sianka is positive. What it could be? So it was the known case of GPA actually. And the patient was on systemic steroid and azathioprine for 8 years. Still the patient is having this type of symptoms and signs. So how we can manage this type of cases? When the patient is already on systemic medications. So we treated the patient with pulse steroid for 3 doses and rituximab also started. Because rituximab will take some time for action. So by the time pulse steroid did wonder. So if I see this patient as during the COVID time, she sent this video from her home only. It has come back nicely. So the final diagnosis is orbital apex syndrome in granulomatosis with polyangiitis. Orbital apex syndrome in the case of the GPA can occur because either the granulomatous orbital mass, compression effect, or it could be because of the small vessel vasculitis causing optic nerve vasculitis, and that causes this loss of vision. So the standard treatment for severe GPA is to induce the remission with immunocompressive such as rituximab or others in combination with high dose of corticosteroid. Scenario 2, 23-year female who came with bilateral recurrent swelling of eyelids, ptosis, proptosis for last 3 years. The swelling, itching, and pigmentation of the right cheek for 2 years. There is off and on treatment with oral steroid during the recurrence of the disease. The swelling was non-tender, granular fill. There was regional lymphadenopathy. The anterior posterior segment NAD, Sarma test was NAD. So what it could be? This is something new. I didn't know at that time what it could be. So this was the lab investigation. There was high eosinophil count. Serum IG was high.
Miculix, no?
No. This was the, Miculix is a differential diagnosis definitely. So you can see the MRI, hyperintense bilateral lacrimal gland, all the muscles are enlarged in both the eyes. So final diagnosis came from the lymph node biopsy.
Kimura's, yeah.
It was a case of Kimura's disease. Oral prednisolone we started and we tapered the dose and we had to continue the oral prednisolone for 1 year. The patient improved, but she again came back and after that we started azathioprine and she's in maintenance dose. She's doing well now. So this was the follow-up 2 months. This was the case which we reported in IGO also. KD is believed to be an allergic or autoimmune response to an unknown stimulus. The differential diagnosis, as you told, that it could be a case of TED, it could be a Miculix disease or a Hodgkin's disease also. But most close differential diagnosis is angiolymphoid hyperplasia, which actually the similar picture, eosinophilia is there, but the normal IG is there, In KD, the IG is, level is high. And also in HP, you will see in LHA, vascular proliferation of endothelial cells. KD may be associated with renal function. So the important thing is that these systemic investigations and the close follow-up of the patient for long term is very much needed. The patient, if the patient, you have to send to nephrologist. If it's a minimum symptoms and signs, then you can do observation. Medical treatment like in the form of cetirizine, corticosteroid, cyclosporine, retinoid also has been advocated. In case of recurrent attacks, intravenous immunoglobulin has been advocated. Surgery, if it is an isolated lesion, large lesion, surgery can be done. And in recalcitrant cases or in large case tumors like swelling, can go for radiotherapy. This doesn't have, this is a good thing, this doesn't have any malignant potentials. So coming to the next scenarios, 18 years female who came with bulging of the eyes with mild pain for last 3 days. The patient gave an history of fever, headache, vertigo, stuffiness of the nose 1 week back. History of similar attack 8 months back. Extraocular muscle restricted movement. There was congestion of the eyes, episcleritis, interstitial keratitis. As you can see, the interstitial keratitis is actually at the periphery, along with submandibular lymphadenopathy. This was the CT picture. CT picture is showing lacrimal gland enlargement and the fat plane obliterated, as you can see. So I thought it could be a case of GPA. But no, it was not a case of GPA. Pianka was negative, though in 80 to 90% of the cases, Pianka positive in case of GPA, but 10% cases of GPA may be Pianka negative also. So finally, we diagnosed it as the patient had a conductive auditory deafness, which the patient was giving a repeated history that I can't hear. We started the patient on high-dose oral steroid. So clinically, we diagnosed it as a case of typical form of Cogan syndrome. Cogan syndrome is an autoimmune disease. It appears with all this may be typical or an atypical. In a typical case, as I told, this could be a typical case. So all these lesions features will be there. In atypical cases, these conductive auditory deafness may appear 2 years later. So this was the picture, final picture. As you can see, the patient is doing well with this disease only. There is we could not do any biopsy or as the patient improved and she didn't come for follow-up. This was a 50 years male who came with redness and loss of vision in the left eye for 1 month. Visual acuity, PL was denied as I told, RAPD, EOM restricted, disc edema. You can see the MRI picture. There is a hyper-intense lesion. All the muscles are enlarged in the left eye. It has extended up to the orbital apex. So that is most probably the cause of the PL negative patient. Lab investigations were not very suggestive. We did started with pulse steroid. Patient's visual acuity didn't come back, but otherwise the patient's signs and symptoms are decreased. So in this case also we diagnosed that in a case of orbital apex syndrome, idiopathic orbital inflammatory disease in OS. Scenario 5 actually. 30 years female. She came with swelling, mild pain, 2 days right eye. In other unit people, they started the treatment with as a case of orbital cellulitis. But there is not much of pain, mild pain. There was no systemic history. But she told that she had a similar attack 1 year back. Visual acuity, extraocular muscle, normal. Investigations, the only thing is that we, in investigation which we found, serum IgG4 level was very high. We started the patient on prednisolone in tapering doses. In MRI, you can see in the CT scan, there is bilateral lacrimal gland enlargement. After starting the prednisolone, the patient improved. But in this case also, patient didn't come back. So it could be a case of IgG4 orbitopathy. We can discuss later on at the end of our presentations. Another case, proptosis bilateral with lacrimal gland enlargement, lab investigations negative. Look at the MRI pictures, the muscles, the nodular enlargement of the muscles. In this case also, initially we thought it could be a case of Wegener's, but it finally we diagnosed it as a case of idiopathic orbital inflammatory syndrome, because this type of the MRI picture, the muscles, they are more seen in case of IOID. This was the last follow-up when the patient came. 32-year female came with a swelling erythema in the lower lid. There is a history of trauma by a palm tree branch 3 years back. The patient was conservatively managed outside. This was during the COVID time. So she came to us with this picture, what you can see. And we did the CT scan. In CT, there is a linear hyperdense shadow you can see. Looks like a foreign body. So what we did is that we just directly we went for the see. Initially there was no foreign body we could found. The foreign body was totally encapsulated. We had to cut the capsule and then we took out the foreign body. So this type of cases also come with an hot orbit or inflamed orbit. So I'm not showing this now, how to proceed for a diagnosis of an inflamed orbit. These are my references. These are my team in various medical colleges. So to treat a case of inflamed orbit, don't burn your finger to treat an inflamed orbit. Thank you.